This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast.
Cool, and we're recording. So, Lindsey, thanks for joining us. Do you mind introducing us, introducing yourself to the group?
Yeah, thanks for having me. My name's Lindsey Ewing. I am a critical care flight paramedic in Virginia, but my whole life up until the last 4 years or so has been 911 medicine. So that's kind of where my passion lies. And then I am also a paramedic instructor on the side. So most days when I'm not working or occasionally still volunteering, I'm usually teaching a class somewhere.
Cool. Dr. Lawner?
What is up, everybody? Good to see everybody again. My name's Ben. I'm a pretty crappy paramedic and an even worse firefighter. I did have a career as a firefighter paramedic with Alachua County Fire Rescue. That's back in Florida. And now I do medical direction for a local critical care transport program and the best fire rescue service in the city of Baltimore.
Well, thanks for joining us, both of you. Thank you so much for joining. Today we have 9 kind of like rapid fire topics that we're going to be talking about. And Lindsey, I'm going to actually hand it off to you to read your first one and actually tell us where you got these, because of course our listeners may or may not follow your page. And we're definitely going to plug your page at the end. So if I forget to do that, please remind me. So I'll hand it off to you for the first one.
Sure. So I connected with you guys on my Instagram page, which is the Prehospitalist. And one of my favorite things to do on that page is to get everyone involved, right? People submit to me the things they want to talk about, their areas of expertise. And so recently I had asked, what are some relatively small clinical practices that you all use on a daily basis that can make a really big difference in your care with your patients. And so I picked 9 of them that I really strongly agreed with. So obviously there is some bias here, but these were mostly submissions from the Instagram world. But of course, I'm on board here. So the first one is pretty straightforward, I think, and it's talking about some basic BVM technique, right? And I think that this can't be overstated. I think we all know like how terrible EMS providers are at BVM ventilation. Like all of us at all levels, we suck at it. We do it too quickly. We do too much tidal volume. We don't have a great seal. And so there's really no reason that we shouldn't always be doing a 2-person technique when that manpower is available. I understand that in some extremely rural areas, that's not always possible, but in our more suburban and urban areas, there's no reason that we shouldn't have someone at the head doing a 2-handed mask seal, either double EC or thumbs down with a jaw thrust, and ideally having an inline capno there as well to actually monitor the efficacy of our ventilations.
It's a great topic. Actually, I just taught that today. Literally like 3 hours ago to our new medic students.
Yeah.
That's what we're covering today. And it's amazing. Like you're still catching people throughout the fire service and EMS service that are doing, the full bag squeeze or the EC all the time or some variation of that. And we're trying to, like you said, push them towards this double EC, this 2 thumbs down. We even went to, during COVID in my agency, using the CPAP mask because it was, the circuits we use, we're able to strap it on, and now you're doing 1-person BVMing with the same seal as a 2-person technique.
Yeah, and Josh, I don't know if you've seen this as well, but what I notice in classes, even when I have like tenured providers who have been practicing at like intermediate levels of ALS, when you go to actually have them do a 2-person BVM, like how many times in your class does someone try to do the mask seal from the side, and then the person is bagging at the head? And these are these tiny little details that if you don't actually have people practice it on a regular basis and say, no, mask seal is at the head, squeezing the bag from the side, it can make a big difference in practice.
Yeah, totally agree with that.
Ken?
No, I don't have anything more than what Lindsey or Josh said, honestly, because the first thing that came to mind when they started talking about this is when we have new EMT students, especially in the beginning, and the first thing we teach them is to get at the head and to actually get their hands over the face to hold that seal, because so many of them do instinctively go off to the side to try to do it, and it just doesn't work. And you see it in the field too. You'll have somebody who's not breathing, and somebody's just goes to the side of the patient, tries to get a seal, and then they wonder why they're not getting chest rise or why they're not getting end tidal on the monitor. And it's like, well, it's because you don't have a seal. You're not getting any gas exchange. It's that exact problem.
Yeah, exactly. Yeah, I think that one's pretty straightforward. The second one I had on the list was resuscitation.
We're not done with number one.
Oh,
Yeah,
sorry.
I was going to say, yeah.
You were being so quiet, Dr. Lahner. I thought you were just like, well, okay.
No, I promised this was going to be controversial, but I didn't have a good way to squeeze that in. I was going to talk about the practice of naloxone for hypoventilation, which is great. I'm just kidding. But so all I would say for this one is you need to use your adjuncts because number one, especially in pediatric patient populations, you've got a large tongue. You've got to let the NPA and OPA work with you. And then number two, I completely agree with the issue of end tidal capnography because we like to think that we have great compliance, but, these hands have bagged, I don't know how many people to death. I'm not very sure. But the most important thing is to judge the quality of your efforts. And like everything else you do in pre-hospital medicine, you have to be able to measure it. And so the only way to assess the quality is to look at a waveform. So I would just emphasize the end tidal capnography and then also really advocate for the use of adjuncts.
Yeah, I gotta stress that because the my question for you, Dr. Larner, is gonna I do have a question for you, but that's like one of my pet peeves. Folks there seems to be a disconnect where folks just don't want to use end tidal with BVM alone, and then as soon as they have some sort of airway.
There's a state agency that said
don't do that.
BLS.
Don't do that. Stop it. We're gonna edit that part out. Okay. No, but it's huge. I mean, and it is difficult. And you're right. I mean, I joke, but that is a training thing that we can't really utilize. That I mean, we can always train folks, but if they can't use it in the real world, then that's certainly a limitation. My other big pet peeve with BVM ventilations is when people crank the whole bag in, and it's really like in terms of like when I teach this, I try to teach it as the chest is a cylinder that has a fixed wall. And you can only put so much stuff into it. And the more air you're pushing into this person, the less blood is coming back to them. And that seems to help. But I just wanted to ask you guys, what are some tips and tricks that you guys can give to folks that maybe teach others to kind of help them guide through their students and guide their students to how not to overbag them?
So today, shout out to Dave Pfeiffer, hopefully future guest on the show. He had a post of a adult ambu bag, and he put 500 mLs of fluid in it and showed how little there is in the actual bag, what 500 mLs actually relates to, and to show like, hey, this is how much this actually can do. This is how we're going to deliver. And we're talking about, working over the plastic end of the BVM, the quote unquote football method. Your pinky out, so you're bringing your thumb to your middle finger and your index in the middle, trying to squeeze it in over a second, not slam it, get it in there, but don't do too much. And we're trying to bring back PEEP valves with us in our department, and PEEP valves being part of that, making sure they're delivering the right amount of pressure.
Speaking of controversy, I'd be interested to hear Dr. Lahner's thoughts on this. So I think it's that same post that Pfeiffer posted with the green liquid in the BVM. he was talking about how actually pediatric BVMs can be profoundly inadequate for the use of ventilating adults. And there has been, a big turn in agencies trying to kind of combat this hyperventilation issue by replacing adult BVMs with pediatric BVMs to avoid hyperventilation. But his post kind of pointed out how that is not ideal. And so I know our program very recently went back to using truly adult-sized BVMs for adults because we were having issues ventilating with the peds.
No, I would say two things about this. And this is a podcast where Moose and Ken know that we resist simplicity. And I completely agree with you that the idea of utilizing a pediatric BVM for the solution of inadequate respiration is not founded in good evidence, simply because trauma patients may not benefit from 4 to 6 mils per kilo, right? Trauma patients may get 10 mils per kilo. And unless you're going to tell me that your hand has a ability to monitor, has a flow sensor, and you know how much air you're getting in there, we don't know. So I would make a push actually for using what's called a ventilator. I would say there's a couple of things. Number one, ventilate to chest rise, don't overventilate. I think we all can agree to bring this home is that we shouldn't be overventilating. And like I was taught in paramedic school, you can squish the bag against your leg and squeeze the entire crap out of it. We're not talking about that. I would caution, however, that we don't know what adequate is, especially in some trauma patients. And the final thing I would argue is I honestly don't think, to be serious for a second, I don't think that the state protocols, at least in our state, are a barrier here. There is a difference between utilizing end-tidal CO2 to interpret versus as a qualitative assessment of ventilation. So I, as a medical director, we have really pushed out with success in our jurisdiction the use of end-tidal CO2 to say, I'm getting good ventilation or not. But I would agree with you. I don't think that's controversial to say at all, Lindsey. I think unless you know how much you're putting into somebody's chest, and unless you're doing ideal body weight, it's very difficult to figure out how much you're putting in. So don't overventilate and ventilate to chest rise. I think is reasonable.
I wonder how much of this is due to training scars, like generations of training scars, building on each other. Because I know it, and it wasn't that long ago, like when I did my EMT I-99 and even my P, I was never taught the dangers of overventilating somebody. I was just taught, especially in EMT, I was not taught anything even close to that. I was basically taught you squeeze the bag. When you have chest rise, you're good. And try not to do it too fast. And that was basically it. And it's not a knock on anybody who might be listening that may have taught me. But that's basically how we were taught, right? So over time, I learned these things through Con Ed and things like that as they started being hot button issues in the EMS community. But I wonder if we had approached training the right way 60 years ago and not built generations of paramedics and EMTs who learned the wrong way, where we would be.
It'd be interesting for sure, Ken. I think I learned the overbagging by social media, actually. I was talking about with my primary today. I can't remember if it was Decantu, Weingart, or someone else that posted a video of him bagging a simulated lung, and he had tennis balls or oranges around it, and he showed how much it pushed it when you like overbagged or when you bagged football method pinky out. I want to say it was like 4 or 5 years ago, and I was like, oh no. What have we all been doing?
Mm-hmm. Well, it really is the most critical skill that happens in the back of an ambulance every day that is not done correctly by a lot of people. I mean, it's the most simple skill, but it's also the most complicated, just properly bagging a patient.
Yeah, I don't remember when I remember, or I feel like I was taught the right way, and because Ken was my instructor, so that's a good cop out right there. All right, Lindsey, you want to go on to the next one?
All right, so number 2, again, I don't want to beat another dead horse here, but this is just regarding resuscitation prior to intubation. I think hopefully this is becoming a common practice amongst agencies and programs that do RSI, but this is simply the concept that if our patients are not hemodynamically stable-ish or somewhat beefed up before we sedate them and switch them over to positive pressure ventilation, then we can either kill them or cause worse outcomes. So in our program, we carry 2 units of whole blood. So that is certainly emphasized as the first line in our hemorrhagic shock patients. We are given a choice of push dose pressors as well to utilize, of course, fluid boluses as appropriate. But bottom line, even if we're using ketamine for sedation, ketamine is unfortunately taught in so many places as this miracle drug that just like increases blood pressure, and you can use it in anyone, and it certainly does create a catecholamine surge in many of our patients. But those that are already shocky, it certainly has the potential to cause hypotension, especially if we're giving it quickly in high doses. So no matter what the sedative agent is, any sedative can cause a decrease in hemodynamics, and of course, so can the switch to positive pressure ventilation. So a plastic tube down someone's throat rarely saves someone's life. So if we're going to choose to make that move, we need to not do harm in the process.
I know one of you have a comment.
Lana's already smiling.
I mean, I know most of us can only talk so much about it. At least 2 of us, because I know we don't do RSI in my jurisdiction. Ken, I know you guys don't do either.
My medical director doesn't let me do that stuff.
Oof.
Bring it on. It's a great topic. I mean, we got to get it in the right hole first.
But
such a pervasive problem.
That's a whole 3-hour podcast right there, man. I mean, I've been pushing for airway credentialing. My gosh, my medical director.
The resuscitation before intubation, that speaks to even a bigger topic of resuscitate your patients properly. Like, before you consider these much higher level interventions, make sure the basics and like the basic ALS stuff is taken care of first, because we can have all these great tools, but if we deliver a dead patient or a non-viable patient, those tools weren't allowed to do their job properly. They weren't put in place properly. And bottom line, resuscitate before you do anything high level. Make sure that you have a stable patient that's going to accept these life-saving or turning the corner interventions.
So I'm smiling because there's so much to say over here, but go ahead, Lindsey.
I was just going to say, like, there's so much to talk about ego here. And again, like, I don't want to spend too much time on it because this could be a whole separate podcast, but so much of this is acknowledging like what we can and can't do and what we should and shouldn't be doing for the patient. And so, if we have a trauma patient with a blood pressure of 60/40 who's bleeding and we don't have blood products and they're altered, but they're maintaining their own airway, can we justify an RSI? Sure. Is that what's best for the patient? Absolutely not. Right. So it's being able to take the step back and say, yeah, I can do this. It's probably going to do harm to the patient, or I can deliver them altered with an intact airway, but with hemodynamics that are intact. So Dr. Lana, go ahead.
This is one of the most misunderstood subjects, I think, in pre-hospital medicine. So to push back on the captain, which I never do, the ability to do RSI has to be predicated, and I think Lindsey referenced this, on your ability to resuscitate. So if we are honest with ourselves, right, in order to resuscitate, and you name what type, a septic patient, a COPD patient, a trauma patient, we need a bunch of things. We need post-ventilatory management. We need a ventilator. We need not just push dose pressors, but a bridge to an infusion, because the post-intubation hemodynamics are so complicated. Doesn't mean that paramedics can't do it, but if we're talking about RSI and we're talking about how we have to resuscitate before we intubate, that discussion has to be predicated upon the ability to deliver those things. And it's not because it's too complicated. It's because that what patients need is incredibly diverse, broad, and changes in accordance with the clinical context. So when you look at jurisdictions that perform RSI, you typically have a lot of training. And remember very clearly, you need at least 50 intubations to become quote unquote comfortable, and maybe 12 to 24 intubations per year. So we're not even talking about the baseline, but also that full complement of interventions so that you can monitor your patients appropriately and deliver what they need. And I'd also point out, this is not just Ben Launer's opinion. If you look at, nobody knows why patients are dying. Now, if you had other medical directors on the show, like one of my colleagues in Virginia, he'll say it's the paralytics, and another medical director will say it's the sedatives. The bottom line is, For the past 20 years, we have been intubating shocked patients, and there is a 30 to 40% incidence of peri-intubation cardiovascular collapse. And if that is not caution enough to say, let's take the healthy pause, then I don't know what else would be. So great discussion. We still can't suck paralytics out once you give them. So I would, again, very vociferously emphasize the need that we should embrace that full complement of resuscitation interventions. But
What is that word
very
you just
difficult.
used? Can you
I
teach us
don't
that
know.
word?
I just looked at it up in the thesaurus. I looked it up in Urban Dictionary.
Vociferously? Was that the word? Okay, that's like the
I don't even know.
$50 word of the day.
I don't get to use multisyllabic words unless I'm on Moose's podcast. So I have a couple of other words that I'm going to use later on in the show as well.
Do you have a list?
Yes, but I'm waiting for the IV asthma discussion, and then I'll use a lot of the words.
That's next.
I mean, I can't think of a better transition if any of you have anything else to say.
Ken Sanders got a laryngoscope and some push-dose epi. Let's go.
All right. So number 3 is about the crashing asthmatic and anaphylactic patients, specifically with bronchospasm. So this comment is based around the AMAX4 algorithm, which is out of Australia over the last couple of years. You guys can go to amax4.org and look it up. But the nitty gritty is there was an Australian ED physician whose teenage son had a history of a food allergy, was exposed to the allergen, had a profound anaphylactic reaction with bronchospasm, was treated with IM epi, but proceeded into cardiac arrest. Upon getting IV epi, he got ROSC, but the ER management was extremely slow and not aggressive regarding airway. So he went back into cardiac arrest, and the ER doc ended up having to crike his own son after multiple failed ET attempts by the docs in the room. And they did get ROSC, but by that point he had an anoxic brain injury. So this physician's kind of mission over the last couple of years has been to provide an algorithm to prevent that from happening. So to be clear, this is about these patients who have such severe bronchospasm that they are requiring mechanical ventilatory assistance from us. And so the point here is that we should have a general awareness of this possibility. And if it is not within our protocol already to act upon what he is suggesting in his algorithm, at least have a spiel ready for med control to ask for it if the situation arises. And what he is suggesting that I think is most relevant in the pre-hospital setting is that if you have a peri-arrest patient, it's going to take 8 minutes or so for IM epinephrine to take effect. Whereas hypoxic brain injury happens in 4. And so his suggestion is in these crashing patients that we go straight to a diluted IV epinephrine. So he recommends 1 mic per kilo of push dose epi, or just a 0.5 ml of cardiac arrest epi for an adult, which is 50 mics. Earlier intubation in these patients, because BVM and supraglottic airway are simply not going to be as effective with those high airway pressures. Now, what I will say is it kind of goes back to our previous discussion. There's, a lot of risk with a failed airway in these patients. So should we be jumping to a tube in the pre-hospital setting if we're not well practiced? Probably not, right? But I think one of the quickest and easiest things we can do for these patients is at least provide the diluted IV epinephrine if they are in such a dire state that the IM epi is just not going to do the job fast enough.
So, just as an aside, and Josh might know the answer to this, isn't that the same scenario that happened to Dr. Safar's child in American Sirens? Am I remembering that correctly?
Oh yeah, you're right. It was an asthma. Yeah,
Yeah,
it was
his daughter.
Yeah.
Yeah.
Look at that memory, man.
Yeah.
I like connection there.
I have my moments. It's a very interesting theory, though. I mean, of course, IV epinephrine would work more quickly, right? So it makes sense in that route. And I've been watching Dr. Warner's face the entire time, and I can't wait to get to him. But I mean, for my dumb paramedic brain, I'm like, yeah, that makes perfect logical sense. But I feel like we're about to hear why maybe not.
Josh, go ahead. I mean, let's
Well-
do it. I saw it on a Weingart podcast one time, and
Me?
I thought,
I haven't said anything yet about this.
I'm waiting for all of them.
I mean, I heard about the AMAX 4. I think it was you that shared it, Lindsey, or maybe you tagged someone else in a story about it. I know you did a post about this in general. I'm right there with Ken that in my paramedic brain, yes, this does work. But also knowing that there can be some adverse effects from giving your 1 to 10,000 straight IV. It is, in the 50 microgram dosage. Yes, I understand that. I honestly don't know enough to make a good comment. I
So-
only
Lindsey,
did admit that.
Lindsey, do you mind explaining for our listeners, like, what's the history? Obviously, I'm not too worried about the history. What are the physical exam findings and vital signs findings that I would have for a patient like this? Versus, I mean, I know you kind of insinuated a bit, but what am I finding that would lead me towards doing this sooner than later?
Yeah, so this is a patient that has progressed from respiratory distress to respiratory failure. So in your asthmatic, you may no longer have wheezing. You may have that quiet or silent chest because they are so bronchospastic that there is minimal air movement whatsoever. They have so much air trapping that it's essentially resulting in a obstructive shock pathophysiology. So they are likely becoming hypotensive. We know that in early stages, asthma is more of a ventilation problem than an oxygenation problem, but in later stages, it becomes both. So once our sats start to drop in an asthmatic, we know that's ominous. So that's something you would see here as well. So a patient who is simply not moving air adequately to sustain life, likely an altered mental status, arguably would definitely have an altered mental status, and is requiring positive pressure ventilation attempts by us.
So I think this is interesting to talk about because the treatment of status asthmaticus, we see a couple of these, and in the critical care world, we're transferring these patients that are often mechanically ventilated due to asthma, and they're a huge challenge. So I certainly would not dispute the idea that IV epinephrine may work a little bit faster. There is a question as to whether these patients are hypoperfused. Remember, in the setting of status, your adrenal glands are pumping out epinephrine and norepinephrine, and these patients are often hypertensive, they're tachycardic. And what's interesting is that before these patients get intubated, a lot of them are getting ketamine, multiple doses of epinephrine, which actually gets fairly well circulated into the plasma, even from IM, not necessarily sub-Q, and we still don't see a difference. And all I would say is we can consider that. We don't have any good data on IV epinephrine, but the main pathophysiology is the fact that these patients, as Lindsey said, cannot exhale. So you have a patient who is so hyperextended because they're so obstructed that they need time for the steroids to work and the bronchioles to dilate. And what's happening is these patients aren't exchanging gas. They're incredibly acidotic. So what they actually need is to exhale. They need borderline inverse IE ratios so that you can actually get the obstruction down. They actually lose the ability to breathe because their lungs are so extended. And oftentimes, and I would say in our case series that we have not only in the air side but the ground side, what actually happens really well with these patients is if you just give them time to relax, if you push on their chest, if you allow their end tidal CO2 to rise, and you try to avoid, it's not necessarily about the intubation, but it's basically intubating and ventilating them at a physiologic rate. That is not good. It is low tidal volume and it is low rates to permit the restoration of normal physiology. So there is a research question here, right, that we can look at IV epinephrine. The challenge, though, is that these patients, you get fairly good plasma levels, and sometimes when these patients are so when they're at the peak of their status exacerbation, they just simply need time to exhale. And sometimes you have to look at other things like tension pneumothorax and literally press on their chest so that all that obstructed air can relieve that obstructive shock phenomenon that Lindsey was talking about.
Josh, no response. I'm kidding. Since we're targeting Josh for this one,
Yeah, I was like,
We're trying.
And I think Mustafa, just to be clear, because I don't think I said it explicitly in case any of the listeners aren't familiar, that the epinephrine is being given to these patients for beta-2 agonist properties, right? It's being given not for the hypotension, but for the bronchodilation. And the thought process is that these patients are so clamped down that, like, even if you hypothetically like bag in a neb or whatever, like those inhaled agents aren't even able to get where we need them to go. So if we can bronchodilate from the inside out whilst we are responsibly ventilating them, like Dr. Lahner said, giving them enough time to exhale so they can actually exchange gases, then maybe we have a better chance at resuscitation. But I definitely agree that there's a really good research opportunity here for this topic.
I don't know. Primatene Mist has been on the shelves for a long time, and remember, epinephrine is not benign. There's a black box and a caution on that because of the cardiac dysrhythmia when these patients are already so wrapped up in their sympathetic cascade. But I would say there's a lot of common ground here because despite all of the joking and the fun, we always want to bring it back. I would argue that once you have an effective ventilation, we don't move to parenteral epinephrine soon enough. Meaning you cannot rely on an inhaled beta-2 agonist if somebody can't breathe, right? So all of this emphasis on bagging it in, continuous nebs, if you have ventilatory failure, you need to start giving IM epinephrine. And if you're not making things happen, you need to give more IM epinephrine. Because if somebody can't breathe, right, no matter how messed up their heart is and they're asphyxiating, you're never going to get them back unless you reverse the physiology. Or we can just crash them on ECMO if you want to have Patterson on the podcast show. We'll put him on ECMO.
I'm about to trigger the doc here. You guys ready? Hey, what are your thoughts on terbutaline?
Terbutaline. I don't know. Great drug. I think you should. I think you should probably publish on it and write a protocol. And we'll talk about it a couple times. You should aerolize it. It's great. Very cheap.
Okay then. I would love to measure your blood pressure right now, buddy.
We can. Well, it's such a crappy beta. It's a non-selective beta-1 and beta-2 agonist anyway when it's given parenterally, but we would love to talk about it. I know you've heard the terbutaline spiel too, but good stuff.
Many times, especially in early COVID in our meetings. So trust me, I have a little bit of trauma associated with terbutaline.
We'll bring it back.
We definitely will. All right. Anybody else have anything on this before we go to the next one? No? All right. Lindsay?
All right. So number 4, definitely a quick one here, just regarding sepsis alerts. So we are all super familiar with stroke alerts and STEMI alerts and questionably OMI alerts, depending on where you practice. But sepsis alerts should be prioritized as well. There's plenty of literature that shows that just calling a sepsis alert pre-hospitally decreases the time to antibiotics, which could affect the outcome of our patients. Now, I will say, I think this depends on the facility that ground providers are transporting to, because some facilities don't give a shit about it, right? They don't really do anything, nothing changes. But some facilities do have the infrastructure in place that it does speed things up and may actually make a difference in patient care. And it's one of those things that's so quick and easy on our end that if the patient meets criteria or our clinical assessment otherwise says that this looks like sepsis, then might as well give someone a heads up. Can't hurt.
I think that's something Maryland does very well in our protocols is we have a sepsis alert protocol, and you're supposed to actually use that terminology, sepsis alert, when you call the hospital. So I definitely agree with you. It's a good thing to do. Whether or not the hospital acts on it is up to the hospital, of course, but I think that is there. I did want to go back to something you just said. You said a OME or a
OMI.
Oh, OMI. Okay.
Yeah, occlusive MI, since, you say
Okay.
STEMI, and nowadays all the hipp kids are like, you can't
Yeah,
say
that's
that
a new
anymore.
word.
It's OMI,
Yeah.
and, okay, but STEMI is still in OMI. But anyway, yeah, some people are calling alerts based on the OMI criteria, which I think is fine in some circumstances. But again, that's another topic.
That was a topic brought up recently, and it's been hotly debated by many different people over the past couple of years. So the sepsis alert, I agree, Ken, that Maryland does a good job of having in the protocols. But I brought it up in our sepsis talk with Dr. Andy Anconi about how I went to a hospital the day before that recording and called a sepsis alert. And the charge nurse looked at me and said, "Why? We're going to just do the same thing regardless." And it's one of those almost defeatist things, why? But I also get why we do it. I remember when we didn't do it. I remember when it was starting to get introduced nationwide as this thing that we should be doing in EMS, but it takes a lot of buy-in from the hospital. And I don't know if Dr. Lahner, you can talk about how that's supposed to happen or something to that.
I am pretty skeptical of the sepsis alert, and I promise some controversy, and here's the reason why. So what if you have somebody with a pneumonia and a fever, and you call in pre-hospital sepsis alert? Now so in terms of the buy-in, if we have a waiting room of, let's say, 50 people, there's 30 that are waiting. What are we going to do? We're going to jump on the patient, give them antibiotics for an indiscriminate cause, potentially cause charm. I think where we agree on this is that sepsis is very nuanced. And if we want to get this right, sepsis actually has a lot of similarity to stroke, meaning that it's complicated to recognize. And if you look at the pre-hospital studies, it presents very differently. And my point is, a young, healthy patient with pneumonia is very different than an elderly patient with a UTI who may be altered and may not meet septic criteria. So the challenge is that the CMS metrics are very aggressive, and that means that we should essentially be giving everybody who has a fever and a sore throat IV antibiotics, right? So it's not the fact that we want everybody to be defeatist. It's the fact that we want to identify the patients that are most at risk and act upon them in a responsible way. And that is, I think, where we all have an opportunity to be very nuanced about what we're doing, because I know this is sort of like sepsis heresy, but not everybody with a fever and tachycardia needs immediate broad spectrum antibiotics, a lactic acid level. And you talk about buy-in, Josh, the nursing care that is required to do that when you have an ED that is filled with sick people is very difficult. So I agree very clearly. Let me be very clear. Don't edit this portion out. I agree that we need to tag patients that are at risk for deterioration. However, what needs to happen is that we need to do our due diligence to make sure that we encompass patients that are really at risk, the immunosuppressed, patients with lupus, HIV, atypical presentations. Let's also not forget renal disease patients, because they can have bacteremia and will never have a fever, right? So we're waiting for the sepsis alert to show up, but these patients are so sick because they don't mount the normal immune response. And then we have to have a measured response on the back end. And I would just very politely challenge that the CMS core metrics are a little bit different than the American College of Emergency Physicians, that says, you know what, we can understand what our pre-hospital colleagues are saying and make an appropriate decision and give antibiotics within a reasonable time frame. Because the other thing these people need are blood cultures. And I don't know if you've spent any time around our Baltimore hospital, but it's really hard to get a vein sometimes. So again, just to bring this back, let's focus on recognition and make sure we're septic alerting the correct patients. Because I get so many of these that come back that have sore throats in the waiting room, and these patients don't need aggressive blood cultures and antibiotics. They need Tylenol and an evaluation.
So would you say, Doc, that maybe how the protocol is written maybe leaves too much room for your kind of ambiguous quote unquote sepsis alerts that aren't really truly like in need of timely antibiotics or cultures or so on and so forth? Maybe they need to be more stringent on like, hey, look, here are the kind of the SIRS or the SOFA or criteria built into our protocols, but we're really looking for the patient that fits this much higher category. Do you think that's more appropriate?
I would argue that the patients that are at risk for septic shock, elderly patients, are the ones most at risk, right? And those are the ones that, let's talk about the reperfusion exam, let's talk about the antibiotics, which is within 3 hours. So again, it's really training on the front end so that we can have a conversation and use good clinical judgment. And the problem, right, that we're seeing in pre-hospital care is we need a protocol, right? It's either black or white, or it's not happening. And I think that's where it's a huge challenge. So I would argue that you're correct. We probably need to identify the patients that are at risk of septic shock, identify some high-risk categories, and those are where we can expect buy-in from our hospital colleagues too, because you just get triage fatigue, the stroke alerts, the STEMI alerts, right? All sorts of alerts. And yes, it is our job to sort through that. But it's pretty clear that there's a lot of significant over triage. And once we identify the patients that are most likely to benefit from these interventions, i.e. the patients that are at risk for septic shock or atypical presentations, we can probably be a little bit more nuanced with where we apply the criteria. And feel free to...
It would be interesting to look at, it'll be interesting to look at pre-hospital activations of sepsis versus back-end treatment for the past couple of years. That would be really interesting to look at in Maryland. Do you remember the latest iteration of the sepsis protocol when that went live? Was definitely pre-COVID. I don't know, maybe 2015, you think? 2016? So we have a sizable amount of data, I think.
It's when we added Apidrop.
Yeah, I think it was like
Oh, was that the
29.
most recent one? Okay.
So 2 or 3 years.
I mean,
Yeah,
what does the group think? Because I would argue we have a lot of opportunity to make a good judgment. You have end-tidal CO2 in many
Yeah.
cases, right? We've got paramedics that are doing the history. We've got lots of ways to identify patients that are at risk.
I mean, what I'm seeing in my head is like a two-tier checklist, right? So they have like criteria, physiological criteria that we're meeting, and then kind of what you're describing, like the history, physical stuff, which we already kind of do, but a more expansive subset that actually triggers a more viable alert. I mean, that's kind of what I'm getting from what you're saying. I mean, is that correct?
Yeah. I mean, we all agree that it's important to raise the alarm for patients that are at risk. But I think given, we work in an environment where resources are they're very limited, right? So we want to make sure that when we call the alerts, we're doing the right thing and that we're matching it to the patient population that would most benefit. And nobody would argue, right? We don't want to have the situation where Josh described where you have a pre-hospital clinician saying, hey, sepsis alert, and people are saying, we're not going to do anything. We just need to somehow make that decision and maybe incorporate more data points. I think this is another fascinating discussion that has not been solved by existing research. There's some studies that show that mortality doesn't change. There's some studies that show that there's better compliance with core metrics. I think there are quite a few studies that show that the recognition of sepsis, because you're not using all the tools, such as a lactic acid level, we don't incorporate other evidence of end organs perfusion. We're seeing some studies that show there's an opportunity on the front end to recognize better. So I would love to hear Lindsey's more comprehensive septic alert protocol. I don't know what that is.
I don't know what it is either. Honestly, I agree with you guys on all of this, that I think across the board, there's a little bit of an issue of sometimes we are too loosey-goosey on the pre-hospital side of calling alerts in general. And this conversation has come up on the Instagram page, especially with like MIs and stuff, where people tend to have this mentality of, well, I'm going to do what is best I think is best for my patient. And I'm going to call the alert, even though it doesn't technically meet criteria and they can do what they want with it. And I definitely sympathize with that. But at the same time, we have to be realistic that the more we burn out the people on the receiving end, the less good they're going to be able to do for our patients. So regarding sepsis, I think definitely we know our septic shock patients are in that category. Ideally, we would like to catch them before they get to that stage. So I don't know exactly what that criteria is. But I would also argue it's a little bit receiving facility dependent, because I think some of your smaller, more rural facilities are going to be more equipped and able to take care of your sepsis alerts that are more traditional versus, you're transporting to shock trauma and there's 50 people in the waiting room and, grandma who's a little tacky and a little febrile kind of falls down to the bottom of the list, right? So the criteria has to make sense for the agency that's using it and where they're transporting to as well. But yeah, I definitely don't know what the right answer is there.
Well, those are the ones that fall out, right? Nobody likes to go to the nursing home and to have a confused person. It's not an exciting run, but I can tell you that you're absolutely right. Those are the patients that are most at risk, right? The person who has mental status changes due to sepsis, I mean, that is an end organ perfusion problem. And a lot of times, the idea of going to a nursing home is less than exciting, which I understand. But this all speaks to the point that we are all pre-hospital clinicians. The fact that we're all here trying to do better, this is our task, right? We need to own this and figure out how to do it. And I think there's just a lot of room for clinical judgment. Not everything can be solved by protocol, which I know that's not what you're saying. It's just, I really struggle with how to modify existing criteria. Vital signs are kind of easy in some respects. Maybe perhaps we look at the patients that are at highest risk for deterioration, or we look at septic shock criteria to provide guardrails. I don't know. That's why Ken Sanders promoted to the rank of captain. And Moose influences protocol, and I just make recommendations. I don't know. I just review charts, send some emails.
So we can go down a rabbit hole, and maybe this might be too far. We can reel it back in if need be. From the QA side, so I see, unfortunately, a growing trend of downgrades of sepsis patients. I saw a couple today as I was doing some review. And I think it kind of falls into the same category as the downgrades of stroke patients. And that category is, what am I going to do as a paramedic? Okay. Because right now, as Maryland Medical Protocol stands, it says 2,000 liters of saline or lactated ringers 2,000 milliliters before you do an epi drip. And what we found in our testing with some credentialing is that these students were adhering to that protocol hard. And in some maybe seasoned, maybe a little burnt out paramedics, they think, it's just an IV, it's just some fluids. They're going to get that at the hospital. So I know we've talked about amongst the three of us about, these possible changes coming with the sepsis protocol. Like, hey, do we pull the trigger earlier to get perfusion up? Is 2,000 too much? Is it too stringent on the protocol side of saying, hey, this needs to happen before certain interventions? And so I think maybe some of the medics may feel maybe there's not much of a buy-in to patient care pre-hospitally. As horrible as that sounds, I think that's something that I'm seeing as a QA person.
Yeah, I mean, I think the whole fluid bolus thing is kind of like made up anyway, right? Like, isn't the whole like surviving sepsis campaign 30 ml per kilo not really based on super strong evidence? I don't know, maybe Lorna can talk more to that. But I know there's definitely studies underway right now looking at lower dose fluid boluses. And I mean, this is a talking point that I have with paramedic students all the time, is that if your patient is profoundly shocked and like our differential is septic shock, we shouldn't be waiting to get 2 liters in to start a pressor. Like if they're not perfusing, you shouldn't be waiting 20 minutes to dump 2 liters in them. We can do both things simultaneously. So I don't know. I would also argue you should probably have norepi instead of epi to do that, especially if they're tacky, but
it's coming. It's coming in this state soon.
Yeah.
Well, and we want to, obviously, Moose, we reach people across the country and the world with this particular podcast. So we want to mention fluids other than lactated ringers. But, a couple things. I don't think you're down a rabbit hole at all here. I think this is the precise, divide between ALS and BLS. That just because we can't, quote unquote, do something, then it's not an ALS call. And I think that is patently ridiculous. I don't know if that's too extreme or clear, but meaning that I would agree. The whole role of an ALS clinician and a good BLS clinician is to weigh risk benefits and figure out what we should do for patients. And I think it is the ALS clinician or the motivated clinician that can really decide, hey, is this patient at risk for shock, septic shock? Is this patient having a stroke? So while I agree that ALS clinicians are needed for specific intervention, it is all of our collective problem, right, to make sure that we identify these cases. And it's a shame that we ascribe ALS interventions just to, tools, right, because we really want to make sure we can examine people and evaluate their chief complaint appropriately. And I also would agree, I don't think you're going to find any controversy here. Sorry to disappoint your listeners that if patients are not perfusing, I never in my practice would wait on somebody who has a MAP of 50 or no palpable pulse because I need to put in the 30 mils per kilogram, right? Things happen actually in tandem. And so I think part of this evidence-based sepsis protocol that we're talking about would involve the co-administration of vasopressors and likely norepinephrine due to the alpha effects that pressor has.
It's like we said in the sepsis episode, if the map is crap, start the pressors.
Yeah, until you can catch up. There's also the beautiful, here's my second word of the day, vasoplegia, right? So, in sepsis, when you have all this acidosis, you just get all this leakage of fluids, and you can give all the fluids you want, but it's just going to leak out unless some of these patients are so profoundly vasodilated because of the acidosis, and especially with gram-negative sepsis, that, you need to contain the fluid that you're putting in. And of course, make sure if you're in Maryland, the fluid is only lactated ringers. R. Adams Cowley had an idea in 1969. Anyway, go ahead.
Our Lord and Savior.
Make everybody happy. I give all 3 fluids at once, just to make people buy them in. Like plasmolite, I'm like, no, saline. Why? I don't know.
That was honestly, that was really good. That's the kind of rabbit hole I like going down to. That was awesome. Lindsey, you want to go on to hypoxia and hypertension and TBI?
Yeah, absolutely. Another straightforward one here. We know that hypoxia and hypotension are 2 of the worst things that can happen to our TBI patients with increased ICP. And I think we're seeing, more and more agencies become more progressive and incorporate things like hypertonic saline and, Keppra into their protocol for these patients, which is fine, as long as we all collectively acknowledge that there's like only a few things that really are knowingly going to improve the outcomes of these patients, which is things like avoiding hypotension and hypoxia. So especially when it comes to airway management on these patients, these are probably some of the top patients that we RSI in our program as our TBI patients with altered mental status. And we have to recognize that that if we don't prepare appropriately, we don't pre-oxygenate appropriately, we take too long during our attempt, we don't resuscitate appropriately beforehand, that we could single-handedly be part of the reason that their mortality is elevated, right, by causing a hypoxic episode or a hypotensive episode. And so one of my biggest pet peeves is, getting on a scene and, a crew is like, oh, we've given hypertonic saline, but, the patient's sats are 80 something percent. And it's like, okay, that's cool. But like, let's address the things that really matter the most first. That's my mini soapbox.
Yeah, those numbers that come from the studies on hypoxia and hypotension and TBI are kind of terrifying, honestly. How much more the mortality morbidity goes up with these single episodes. Not like, hey, 5 minutes is okay, 10 minutes is okay, it's at 15 minutes you got to worry. No, it's a singular episode of dropping below 90%. It's a singular episode dropping below a systolic of 90. MAP less than 65. It's crazy.
Right.
And we can do things to bring these things up.
Exactly. Like the best thing we can do is the basics for these patients. And I would love to hear Dr. Launer's opinion on hyperventilation specifically, right? Because, we've seen, we also now have this goal of keeping these patients normocapnic, right? Somewhere between 35 and 45, but you'll still see plenty of protocols that say if there's signs of herniation or impending herniation, they should be titrated down to an end tidal of, 30. But to my knowledge, there's really no evidence that actually helps and could potentially hurt. But the argument is, well, if they're herniating, you're just throwing spaghetti at the wall and see what sticks. So I don't know, Dr. Launer, do you have thoughts on end tidal goals in a herniating patient?
Yeah. So it's funny. I think you should also consider a subtitle for this podcast called Controversy and Consensus with Lindsey Ewing. So I want to prioritize, and it's rare that you hear me say this. I don't have much to say about hypoxia. And because the EPIC trial has really borne this out. So if you just go to Google and Google the EPIC trial out of Arizona, Dan Spate, who is one of the few endowed EMS research professors, has looked at a statewide implementation, Josh is Googling right now, of this particular guideline. So it actually looks at, you've got an indication for IV fluid, you've got an indication for oxygen. So I just want to underscore the fact that let's do no harm first. So first of all, the brain injured patient does very well once you preserve their blood pressure, which is typically a higher goal than normally, and you prevent hypoxia. Now, there's a whole other discussion about what happens when people herniate. Now, herniation is uniformly bad, right? We know that herniation is a terrible event. So unfortunately, Lindsey, we do not have a lot of good study to say, what should we do? I think it's very clear that if you hyperventilate people to the 20s, that's bad, and you're going to shut off all vasoactive flow. The challenge is that if somebody has lateralizing signs and is acutely herniating, as evidenced by seizures, Cushing's triad, we probably want to err on the side of very mild hyperventilation, if at all possible, 30 to 35. But I don't think there's good data to aggressively hyperventilate them down. And these other things, right? And this is a great podcast because we talk about priorities. So it is the avoidance of hypoxia, avoidance of hypotension, what to do when patients herniate. And then there's all sorts of other ancillary things that we can consider, right? Maybe some hypertonic saline, maybe seizure prophylaxis. But EMS is all about taking that undifferentiated patient, prioritizing interventions, looking at what could impact mortality, and then moving forward. So I know that's not a hugely definitive answer, but if I had definitive answers, I'd be a trauma surgeon.
Shots fired.
Oh, one just told me I was right. So, yeah.
I think it's important for our listeners to have a basic understanding of why hypoxia and also why hypotension is so terrible in these patients. So when we're thinking of a cerebral perfusion pressure, it's a MAP minus ICP, right? So when we are increasing that ICP due to inflammation, due to increased fluid in the head because of injury, suddenly that number is getting a lot smaller, right? And we're losing that perfusion. We, especially in our neurovascularly injured patients, we're not going to have that catecholamine response, hopefully, to get that heart rate up. And of course, we would. I think it was Sam Weinstock's episode. We talked about the components of the physiological components of the mean arterial pressure, but the components of cardiac output specifically are heart rate and stroke volume. We knock out that heart rate going up, we are not able to get that physiological response to the heart rate, and we're not able to compensate the way our bodies are usually meant to compensate. That's why I think it's really important to understand how critically ill these patients are. And Josh, I agree with you. When I read that, it was the margin of error astounded me. I was surprised. I said, "Oh man!" I just thinking back to some of the patients I've had where they presented to me in that way, and I think it really pushes the point of how aggressively we need to treat these patients. So. Yeah, no, I really like this point. Of all the points that you provided, Lindsey, this was one of the ones that I really thought about. And that's part of the reason in the podcast we try to explain the physiological components behind a lot of these vital signs we're finding, just so folks have a deeper understanding of why. Like I'm helping teach a refresher tomorrow, and one of the things I'm talking about is mean arterial pressure. I think if paramedics understand the underlying components of each of these things we're talking about, I think it helps drive home why we're pushing for the treatment that we're pushing for. I know that was a little bit of a rant there, but no, I really appreciate all of your guys' points.
And I have a small rabbit hole request also for Dr. Launer. I've always felt like this was common sense, but a couple conversations have come up lately that has made me question like my entire existence and identity. So if a patient is, exhibiting Cushing's triad, right? Ominous sign, one of the potential signs of herniation. We have this increased systolic blood pressure to, force drop in heart rate, due to squishing the brainstem, maybe some vagal response, right? So I feel like it should be kind of an assumption, right, that we're not treating that heart rate, right? So the patient has a systolic of 200, their heart rate is 40. Clearly, this is not a perfusion issue. It's a reflex response. There's no reason to increase that number because we would just be doing it to make ourselves feel better, and it's not doing anything for the patient, arguably possibly increasing ICP further, maybe, right? Dr. Launer, are there any situations other than, of course, like a peri-arrest situation, a patient with a heart rate of 20, okay? Just a fairly typically bradycardic patient with Cushing's, are you ever addressing that heart rate, assuming they're hypertensive?
No, assuming they're well perfused, I would not. And we encounter this quite a bit, right? So, and this is where protocols, and I'll say this here too, I think protocols can be very dangerous, right? Because if we just reflexively apply protocols blindly to physiology, we sometimes are undoing the good work that the body is trying to do, right? So as Lindsey said, this is a physiologic response to tailor the response, the circulatory response to brain perfusion. So if we alter that and somehow either negatively impact that or control ventilations in a way that is contrary to that strategy, we can make patients worse. So I think we need to be mindful when the body's physiologic response is exactly what we want. Now, there are some cases, notwithstanding TBI, for example, where the body's compensatory response is not good. So when you have an elderly patient in septic shock and they are breathing so rapidly that they're tiring out and they're becoming fatigued, that's something we have to control. There's some respiratory patterns in the setting of Cushing's where it's not compatible with life. Then we have to assist respirations. But I would agree with you, be mindful of trying to correct what is actually already being corrected. So if the perfusion is already high and the mean arterial pressure is high, there's no need to focus on the bradycardia. I would make if time permits, I would make a slight plea for an EKG. I think sometimes that is absolutely ignored in the setting. And, you're like, well, in head trauma, why am I going to get an EKG? But if you don't know and you have somebody who's unconscious and altered, there are EKG signs, which we will not go into. That's rabbit hole number 3 for you listeners on this podcast, keeping track. There are some EKG signs and symptoms of increased cranial pressure. And it is another tool in the toolbox that you can use to modify your treatment. But yes, I agree with you completely. See, we're back to consensus.
Thank you. Makes me feel better.
Doc, actually on that EKG point, it wasn't my patient. It was probably 4 years ago. A friend of mine ran a guy, just fell on the sidewalk, fall down, go boom, hits his head. He's out. They end up going up to shock trauma with him. And he said in like the last 10 minutes of the transport, mind you, this is a pretty lengthy transport if you know where we are. He said he went through about 5 different rhythm changes. And he's just like, what is going on? It's just, it is a great clinical sign of bad shit. Bad shit is happening. So
herniation, it's fascinating, and nobody knows, but troponins have been documented in the setting of head injury for many, many years. And along with troponins, you can get such things as dysrhythmia, ventricular tachycardia, deep T-wave inversions. It's pretty fascinating. And there's many more people that are quite that have a lot of more expertise about the cardiac effects of increased intracranial pressure. But I agree. Not that necessarily we would do anything about it, but it kind of substantiates your diagnostic impression that something's really going on, and perhaps herniation is imminent.
Cool.
Ken has a lot of room in his head, though, to swell, so we probably wouldn't get that with him. It's very big, and we probably need quite a bit of intracranial pressure to affect that closed space.
There's not a lot going on up there, Doc. I'm sorry.
That's why there's so much room up there, filled with EMS5.
What a perfect transition point to mastering the salad airway.
Yeah, I love me some salad airway. So if you're not familiar, it's suction assisted laryngoscopic airway decontamination, and basically it's just the use of a large bore suction catheter like a Ducanto to minimize failed airways in the presence of copious secretion. So, at our program, we preach leading with suction on every single intubation, no matter what. And I wholeheartedly believe in that. And this is a technique that we can deploy if there's copious secretions that are just normal, typical suction won't take care of. So there's plenty of videos of this online, but essentially you are leading the blade with your large bore suction catheter, suctioning head of the blade, suctioning the glottis, get your view, and then you lodge it in the left side of your blade into the esophagus, maintain continuous suction until you actually have the tube in place. So this can be super helpful in your trauma patients that have tons of blood in the airway, your CHFer who's messy, the patient with continuous vomit, and so on. And so someone always says, well, aren't you causing like so much hypoxia by leaving the suction catheter in place? Well, yeah, but like, so are you by missing the airway because of their copious amount of like spaghetti dinner that they're trying to inhale from last night, right? So I'm a firm believer in this, and I think it can save some pretty significant failed airways in the presence of secretions.
At my agency, we are big proponents. We don't directly say salad, but we do the same thing.
Yep.
Very big proponents. Ken we had a great time training with him this past summer because it was something new to him. And it's definitely helped me on airways. It's helped many providers in my agency on airways. And something, to kind of combat anyone that is thinking, oh, you're creating a hypoxic patient, you're creating this apneic episode. This is where pre-oxygenation comes into play. No DSAT, making sure that we're getting nitrogen washout, we're getting plenty of oxygen, passive oxygenation. You have a high flow nasal cannula going while you're doing this, and you're prolonging that period of apnea so that you can secure this airway and deliver now good ventilations, good tidal volume, and help restore things for the better.
Now, if we want to make it controversial, we can suggest that we, intubate with the catheter itself, right? I have never in my life experienced what I experienced on social media after posting that video. But for anyone that's not familiar, sometimes there's like a modification of this that is referred to as the Seldinger technique. For the love of God, I did not name it that. It's on the interwebs already. All these anesthesiologists are like, that is not the Seldinger technique. And I'm like, hold on, mother fluffers. Like, I get it. It's just the variation. But anyway, so the thought process is you have your esophageal varice rupture patient or your CHFer who's just like a volcano of fluid. And the only way you can get a view is to literally suction your way to it. So you can suction your way to the glottis, put the Ducanto through the cords, take off the tubing, put your bougie in, take out the catheter, and then put the tube over the bougie. I personally think it's a nice oh shit option to have in your back pocket. Shouldn't be needed frequently, but like it's a nice option to have there. However, the anesthesiologists of the world were mortified to hear that this is something that even exists. So.
And it's funny that it's the anesthesiologists that are mortified, because it's the anesthesiologist that came up with the technique
I know.
and officially endorses it. It's quite funny to actually hear him talk about it and what he says about that specific technique. It's very read between the lines.
Yep.
I think there is a little bit of a challenge with this. So we all should lead with suction, right? And I wish I was smart enough to invent the Ducanto catheter, and I wouldn't be like trying to tag myself onto Lindsey to be more popular on social media. I need some help. But you know, the challenge with, and hopefully this is not so unpopular, but when I'm in the cadaver lab and we go to the cadaver lab, I don't know how many times a month I am there. And if I had $1 for every time somebody said they needed suction when they did not need it, I also would be completely not in debt. So the only thing I would suggest is that, yes, we all know we have to lead with suction, which it means that we also have to bring the suction catheter to the patient. I know that's a big deal sometimes in EMS, but I also want to make sure that part and parcel of the Ducanto salad leading with suction technique is that we all have to be facile with direct laryngoscopy. And there has been such an incidence of skill degradation with this. So if you are still not doing progressive epiglotoscopy and looking for your epiglottis and following the tongue to the uvula and doing all of the things, suction may not help you if you're already past that glottic opening to begin with. So my only word of caution, because again, in the theme of controversy and consensus, I totally agree with everything that's been said. This is such an important discussion. You have to lead with suction. You have to bring suction to the patient, but don't forget about the very sort of the finesse technique of DL, because relying on suction to unobscure an airway, if you don't know where your landmarks are, if you have epiglottic camouflage due to blood or whatever is going on, you're not going to be able to see the glottic opening. And that's a real challenge with video laryngoscopy too. So just be careful and practice, because DL, like everything else, is a skill that goes away if you don't use it.
Doc, I have to say, the words today are on point.
Oh, I wish it was my idea.
And then epiglottic camouflage. I'm gonna break that one out. I'm gonna break that one out on Thursday in class for
These
sure.
are gonna be all the hashtags for this episode are gonna be fire. I'm just telling you
I'm
that
pretty
right
sure he
now.
practices that exact spiel in every cadaver lab. Like it's
all the time.
So well rehearsed.
Hey,
well,
Lindsey, you said something here. Oh, sorry. Go ahead.
No, I mean, we have the privilege of teaching medical students, paramedic students, flight paramedics, and believe me, everybody knows how to intubate. Everybody's an expert when they first come in there. So, you know, we all make mistakes, and I think part of the benefit of educating is we all do, right? We all are accomplished educators, and everybody listening to this podcast has some degree of appreciation for education. We have to know like some of the hazards of the procedure, so it's incumbent upon us to really look at the technique, and I think video laryngoscopy has made it a little bit challenging nowadays, right? So, all I can say is just keep practicing that DL, because if you don't know where the epiglottis is, suction may not bring you out of that thing, unless you're going to do a Seldinger technique, which is the first time I heard about that, and feed the Ducanto catheter into the epiglottis and put an eye gel in, and then, I don't know, ventilate the patient on it. I don't even know what's happening next. But
the one comment I was going to make, and I don't know if you said this, Lindsey, but in the notes you sent over, you said in parentheses, not a yank hour. And I can't tell you how much I liked that, because that is, to me, a symptom of we've always done it this way. Every ambulance inventory has a yank hour. That's just what every ambulance has. And sure, the yank hour has a role to play. Mm-hmm. But I mean, I just ran a trauma arrest a couple of days ago, and we just seeing that airway at yank hour would have been useless. And again, we don't have to talk about that specific airway. However, it just reminds me of how important that large bore suction catheter is, and to me, leading with it. Where I still work part time, it's a policy. I mean, and I agree with the policy of we should not be leading with a tube in our hand. We should have that suction in there to help our airway. The other big thing I really like that Dr. Launer said was that progressive, walking into the airway without just jamming it in there. If I had a nickel for how many students I've seen, and also I hate to say it, but I don't even want to know what that chat is. How many seasoned providers, and I'll be the first one to say I've made that mistake. Especially earlier in my career, you just introduce the blade way too deep, and you just don't know what you're looking at. So I really appreciated those comments, and this also does kind of bleed into your next topic of apneic oxygenation during intubation.
Yeah. And by the way, the reason I did not mention the yank hour is because every time I say that word, someone tells me I'm saying it wrong. So I figured I'd just leave it alone. So I'll let you make those comments. But yes, we talked about, setting ourselves up for success, for suction, for intubation. And one of the simplest things we can do, even after pre-oxygenation, is just leave that nasal cannula in place throughout the entire attempt, right? Capnography cannula, I'm sure just for the listeners, if they've never looked at that, the oxygen on most of the models comes out through little fenestrations on the tubing, and the prongs are actually used for sampling CO2. And so while, yes, it can reach higher liter flows, it's not like a direct shoot up the snoot, whereas your normal nasal cannula, you can be blasting 15 plus liters right up both nares. So that should be in place while we're pre-oxygenating, whether we're pre-oxygenating with a nasal cannula plus a non-rebreather or a nasal cannula plus a BVM, whatever. But leaving that flush nasal cannula in place during the intubation attempt can significantly prolong our apneic oxygenation period.
I'm really happy that you brought this up, because this is, again, one of my pet peeves when it comes to when we're preparing our patients for intubation or RSI intubation, and it speaks to the larger physiology of gas exchange at the alveolar level. These things don't just happen in magic isolation. There are specific things that are related to how fast gas moves. Things like the surface area, things like the thickness through that fluid that that the gas has to pass through, the partial pressure. So essentially what we're doing here, and for those of you that are physiology nerds like me, look up Fick's law of diffusion as it relates to respiratory physiology, because this was one of the aha moments for me when I learned this. Hey, stop it, Launer.
Sorry, Fick's law, you got me.
No, but it's important. It helps understand. Oh man, I was going to make a DO comment right there, but I might be go to DO school, so I'm not going to do that, buddy. But no, what was I going to say?
Succinylcholine, my friend. Let's hear it.
But no, seriously, it's really important to understand these. We're increasing the partial pressure of oxygen, right? And we're basically, it's a cheat code. We're building that margin of error for us so that we're reducing those hypoxic events. So this is huge for me. It's one of those things and I haven't participated in RSI in a while, but that it's automatic. I'm automatically pushing for someone to put on that nasal cannula. One of the pushback things I got one time was, it's going to dry out the patient's nares because it's not humidified. And I was like, listen, folks, this patient is so far past dry nair issues. You know what I mean? Like, I couldn't give a lesser shit, honestly. We got to oxygenate this guy, and maybe they can have some, if their worst problem is a nosebleed in 2 weeks, we've done our jobs. So no, I really appreciated that you brought that up.
Well, and something for folks that don't RSI, this can totally be used during cardiac arrest too, right? Mm-hmm. There's no reason we should put that 15 liter plus nasal cannula on during arrest as well. So it doesn't just have to be an RSI.
I'm trying to look up the physiology of turbulent airflow and drying nares. But, the one thing I would say about this is just remember to select your patients appropriately. So this has changed my practice. Apneic oxygenation can also provide you a slight bit of PEEP. And I know Josh had mentioned this earlier, that some people are using CPAP. So remember, you have to select your patients appropriately. So your patient that is at the edge of physiology, that is not breathing effectively, that is already hypotensive and is already hypoxic, this may not be a good sort of apneic oxygenation patient. In order to achieve washout, remember that's predicated upon several vital capacity breaths. So yes, we absolutely want to do both. We want to use a high flow nasal cannula, We want to use, see, it turns out those old nursing home nurses were right that used to put the 15 liters via nasal cannula, and we thought everybody was crazy. They actually were very prescient in terms of predicting a future. But just remember,
they then do 6 liters via the non-rebreathing.
but at least they got apneic oxygenation correct. I mean, let's give credit what credit is due. Just remember, there is a role for BVM oxygenation, because some of your patients cannot be pre-oxygenated. They need to be immediately oxygenated. And I think the point, you talk about tying this in, right, of resuscitation and ensuring the best sort of practice that we possibly can. Trying to optimize your patient prior to intubation is great. I honestly resist the term crash intubation. I think as long as you can ventilate somebody, we have room to kind of play and optimize physiology. So just make sure when we're deploying these techniques, which are absolutely awesome and not controversial, we want to make sure that we are doing the right thing for the patient. The patient without a physiologic reserve that you paralyze is one of the most dangerous and terrifying airway encounters that you'll come across. And those patients are really at risk. So.
A little add-on, Doc. You talked about the nasal cannula and CPAP.
Yeah.
For anyone out there, this is not related to anything we've talked about right here, but highly suggest a nasal cannula at high flow, 15 liters underneath the CPAP mask, along with the CPAP. It's going to get you that residual oxygen. It's going to get more oxygenation to the patient. And because of the size of the tubing, it's not going to break that seal. You're still going to have a good seal. It's going to work great. You're going to get better oxygenation into your patient, depending on the flows that you're working at. So, just a little tip.
I have a question about that. Only because the bulk of the no, it's genuinely a question. So the bulk of the people that I'm CPAPing, actually probably all of them, the one I'm CPAPing, I have nasal capnography on them. How does that affect that?
So Sam would kill me if I didn't say this right now, because he's going to listen to this at some point. You can only do 5 liters, supposedly, according to the manufacturer, through that nasal bridge.
No. So to be clear, I'm not talking about that. I don't. That the holes are useless and crap. I never use the nasal capnography for oxygenation, and I get irritated when people do it. I'm talking about the capture of it.
I've had good results.
It dilutes it.
I thought it dilutes it too. And Josh, the reason I'm saying this is because I literally just made this mistake the last Sunday I worked, and I was like, man, I thought this worked, and then I thought it diluted the reading, and I just lost my reading to the point where I had to remove the oxygen from the capnography meter.
I have noticed this, like if you have any like ambient oxygen flow over the capno, it's going to dilute it. So even if you're running even if you just have a patient on the capno cannula and you're running a few liters of O's through it, it'll dilute your numbers. If you put it under, your CPAP or BVM, but I still like to use it for trending, because you should still get some degree of waveform depending on, the amount of flow that you have. So you can at least still get a respiratory rate with a waveform, and then you get a trend of your values. So even though your patient's true end tidal probably isn't 20, at least you can trend it over time and make some sense of it.
It also depends on if you're using a high pressure versus low pressure system, right? So if you have a low pressure system that titrates a PEEP to an oxygen rate, and your patient is oxygen hungry, then sure, apply the supplemental oxygen. But some of our places, I've certainly worked places where high pressure systems are delivering plenty of oxygen, and it's really a function of the PEEP that your patient needs. There's an equipment question here as well.
Doesn't high flow 15 liter nasal cannula? It's said to be 5 of PEEP. That's what the papers are saying. I don't know.
I mean, if your mouth is a lot. I mean, that's the challenge, right? You see this all in pediatrics. It depends on the patient setting. So there's really an issue if the mouth is closed during this, then probably if the oropharynx is open, it really depends. But that's the thought, is it provides you a little bit of extra PEEP. High flow nasal cannulas as a therapeutic modality is another one of those. There's the 4th rabbit hole for you, or 5th, because Lindsey had one too. So
I've also seen a similar argument against BVMing in nebulizers, because if you BVM in a neb, the oxygen flow into the nebulizer can add extra PEEP as well. I don't know how much legitimacy there is to that, but someone I think on Instagram sent me an alert from their hospital or something that was like, be cautious doing this because you could be adding PEEP to the circuit, which I don't know, was something I never really considered before.
Well, on the flip side of that, a lot of these low pressure circuits require additional oxygen if you're gonna neb something through the CPAP, and that kind of makes sense, right? You're increasing the total surface area of the system, so you need additional flow to compensate for the loss in pressure. No, that's really interesting. I wonder if they're Dr. Larner, do you know anything about that?
Mm-mm.
Fair
No.
enough.
We stumped the doc.
Yeah.
Uh-oh.
But
What? Oh,
I was just
okay.
going to say, emergency medicine, we specialize in that. I don't know. We call people all the time.
All right. So, anything else on that, guys? No. All right. IV before getting nitro.
Okay, so this was submitted multiple times, so I feel like there was a lot of people in the Insta world that have been traumatized by this. But there's a couple talking points here. Is that one? We've all seen the protocols that say, it's contraindicated in your inferior MIs. Some are, more specific to right ventricular infarction if you have elevation in V4R or whatever. The first talking point is that, it's come to light in the last several years that there's not really much evidence to support this, that the thinking was that if there's right ventricular involvement, that patient is preload dependent. And if we vasodilate them, we're taking away their preload and we're going to tank them. But there's been, several studies since like 2016 now, I think, that have kind of looked at the incidence of hypotension in multiple different types of MIs. And there's really not much difference in the inferior RVI category. So I think there's a couple of key takeaways here is that saving any lives in the setting of acute MI, it's more for symptom management. So we probably shouldn't be like fighting to give our hypotensive patients nitro. And second, the awareness that really any patient is at risk of hypotension from nitro if they are already borderline, right? So if they have already a questionable blood pressure, we're not talking about our escape patients that have, a systolic of 180, right? But you've got a chest pain patient with a blood pressure of 110. Okay, well, if they're having an anterior MI versus an inferior MI, is there really any increased risk of hypotension in the inferior MI patient? Maybe, maybe not, but maybe we should just be prepared with an IV either way. Most of the hypotension from nitro we know resolves pretty quickly on its own. It's got a pretty quick half-life, but if it doesn't, then we can just give a quick little bolus there and beef them up.
I mean, that is definitely not controversial, I think, to any of us here. That's been pretty long-standing practice within the state, and then being taught to paramedics actively and making sure it's being done. I've heard many a time a medic say, I got to get this line first before I do anything else, especially when it's a STEMI and they don't have prescribed nitro. And, that RVMI is probably going to like that fluid that you're going to give anyways because they're starving. It's going to help with that perfusion. And yeah, I don't think that's controversial or a new age to any of us. I think that's what we all should be doing.
So do you guys in your protocols in Maryland, does it mention anything about inferior RVI for nitro?
Yeah.
Yep. Very specifically.
Yeah.
Although it is on the
I'll be interested to see if that starts to go away. I don't think there's enough evidence yet to totally get rid of it, but still seems probably a little aggressive.
Let me ask you guys this. I mean, if you have someone that truly has chest pain, I mean, what's your trigger to just use opiates? Or, I mean, why not just do that? I mean, that's what I
do.
Yeah. Right?
Moose, were you a fly on the wall to the credentialing exam 2 weeks ago? I mean, this came up because there was a debate on they didn't give nitro for this patient. It was either they gave it or they didn't give it. And, I brought up that a lot of the studies now are showing it's not, so much of a vasodilator. It's helping with the pain of the MI. It's so where are we going with this whole, do we need to give nitro in the chest pain patient? Can we just skip to fentanyl? Can we skip to morphine if your service is still using it, which morphine is a much more convoluted issue than fentanyl is in this case. But you're also possibly going to get a little vasodilatory effect with the fentanyl. So you got to weigh your options, I think. And I think I'd be more apt to jump to the pain control than the nitro personally.
I just feel like Dr. Lahner is going to have some secret love for nitro that we're all about to find out about. I'm not sure. But I'm totally with you, Josh. if they're hypertensive, fine, whatever. Or if there's any question that this is a CHF, like that's a no-brainer. Those patients benefit from the preload and afterload reduction. But in a patient who is simply a chest pain, possibly ACS patient, like I am not going to stress myself out to give them a tab of nitro sublingually. Like if their blood pressure is 120, 130, I'm just going to hit them with a little bit of fentanyl and see what that works in 90% of cases, I would say.
Yeah, I think it's really important to remember what the purpose of the nitro is, and that's to relieve pain. It's analgesia. It's to make the patient feel better. At least a sublingual nitro. We're not going to stop the MI by giving nitro, which some people seem to think that, 3 tablets of sublingual nitro is going to suddenly like solve the STEMI. But that's not the case, right? The idea is to make the person feel better. So if we have more effective tools in the toolbox, why aren't we using them? And maybe you work somewhere you have Tridil or something. That's really cool. Like we could go down a whole rabbit hole on that. But most of us, that's not the case, right? So what's the most effective thing we can do to help the person feel better in their moment of crisis?
I think my patients are already all medicated with opioids, so they have already had fentanyl and nitroglycerin. They've already, look, I think we've partially caused this with it's protocol creep. Mona greets all patients, and so everybody gets nitroglycerin. I agree. I think the issue with nitroglycerin is, don't forget that it's used very broadly in interventional cardiology. There's intraarterial nitroglycerin. We know there's roles for vasospasm. So there is a mechanism through which suspected cardiac chest pain may be mitigated by nitroglycerin. But I agree that since it's not a mortality-based intervention, I think we overthink this too much. I mean, if they're hypertensive with a cardiac history, it is reasonable to see if you can mitigate somebody's pain. Nitroglycerin has been studied for years, not a mortality-based intervention, to see if it helps. I think opioids are equally as reasonable. If you have cardiac failure, I probably would stay away from morphine. There's some studies to suggest that it can worsen the congestive heart failure and outcomes. But this is, I think, a controversy we've brought on ourselves, because at no time in my emergency department practice, as Lindsey mentioned, am I rushing to give somebody nitroglycerin in triage. It's about relieving their pain. The most important thing we can do is take a good history, get a repeat EKG, and give aspirin. And then if pain control is an issue, I have no problem with giving opiates when it's appropriate. Hey, what's up, man? Joining the podcast. Ken's being called away on duties. So I think there's broad consensus on this nitroglycerin issue, but I think the bottom line is we don't want to make our patients worse, right? And like anything else, it's a clinical decision. If your patient has a blood pressure and they have a cardiac history, it's reasonable to try. Opiates are absolutely reasonable. And as the amazing Captain Ken Sanner, here he goes, as the amazing Captain Ken Sanner said, nitroglycerin is not going to stop the MI.
That's right.
Ken Sanner approved.
And speaking of opiates, I think it's the perfect transition to our last topic, which I think is absolutely controversial. I think we should just give Narcan and not ventilate at all. So
real quick, funny story that we're about to make the segue. And the doc kind of said, he's like, a lot of my patients are already self-medicating with opiates. We had a guy. I was working. I was not on the call, but he was a prescription opiate abuser, came home with crushing chest pain and self-medicated with alcohol and his own opiates, and he coded, and now he has walked out of the hospital. So, I guess the self-prescribed opiates didn't help a whole lot.
Damn.
Massive MI.
The only thing better is if we would have responded and refused him care. Maybe there was a patient refusal involved. You never know. But hey, I mean, that's a good. I see that it's inspirational. I mean, live to have chest pain another day. So good stuff. Yeah. See, we can make a positive out of anything in this podcast and translate it into a teachable moment.
That's right. All right. So the last one is probably like one of my most passionate soapboxes. I know you guys are obviously in a super heavy opioid area. My ground career.
Not at all.
I know you never see it. My ground career was more rural, but we had an incredibly high number of opioid overdoses in that region. And so I feel very strongly about this. The bottom line of like my soapbox is that I get really frustrated when patients blame like the Narcan for patient combativeness when they wake up. I know that anecdote does not equal evidence, but I legitimately, in my entire EMS career, which has been since 2006 at this point, have not had a patient get violent with me after Narcan. And I don't think I'm just like that charming. I think that I have like really like figured out how to not be an asshole, but also like have gotten lucky, right? There's certainly some component to luck here. I'm not saying that some patients won't get combative, because they certainly will. But when we give these patients Narcan and don't ventilate and oxygenate them first, and so they are waking up hypoxic and hypercarbic, and then we greet them 6 inches away from their face, asking them what they took as if we don't already fucking know because we just reversed it with Narcan, right? And then we have like 12 people surrounding them with radios blaring, and there's all these people in the house, and you know, someone's just like, what did you take? What did you take? Like, we're setting ourselves up to get punched in the face. And when people try to blame that on Narcan, it really, really grinds my gears. Like, there's so many steps that we can take to make this a more pleasant circumstance. And people will say, well, you're putting them into withdrawal. How many patients do we see that are withdrawing on a regular basis that aren't trying to kick our ass, right? Like, just because someone feels like dog shit doesn't mean that they're going to get violent with us, right? So I also recognize that in tons of situations now, patients have received Narcan before we get there, right? We don't have control over this. But in a lot of situations, we still do. So it can just be a couple minutes of good ventilations with a BVM on oxygen, give them some IN Narcan, give them the time to wake up. I don't subscribe to the whole just give enough to reverse respirations. Like, ain't nobody got time for that in a high volume opioid system. You can wake them up safely. There's plenty of literature that says we can get refusals on these patients safely, assuming that it's a non-complicated overdose. So I know that was like 10 different directions of a tangent at once, but number one, ventilate and oxygenate before administering Narcan when possible. Number two, manage the scene appropriately, right? Like, combativeness does not inherently accompany Narcan administration. And number three, refusals can be safe in these patients as long as we do a thorough assessment and rule out, as best of our ability, some complicating factors.
Yeah, I think you really hit on a couple things, Lindsey, that are very important to me. I actually just with my EMT students had a conversation with them about when the opioid overdose patient wakes up, what do you say and what do you do? How do you act? Because that's so important. Because I have been on many, 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 many calls where that person wakes up and someone gets in their face and says, what did you take? You overdosed. Wake up. We just saved your life. How is that helping anybody?
I know.
And of course, sorry, go ahead.
No, I'm sorry. I get really fired up over this. I apologize. I'm not trying to talk over you. And like, someone always says, well, of course we care what they took. It affects our assessment. Like, okay, fine. You can ask what they took, but for the love of God, it doesn't have to be the first thing you ask them. Like, clearly there was an opioid involved, seeing as how we gave an opioid antagonist and they woke up, right? So like, even if they were speedballing, even if they mixed some prescription meds in with it, like whatever, we can ask that later. If we just step back and give them some space and say, hey man, how you feeling? You okay? You know, you were unconscious for a minute. How you doing? You know, in a non-threatening way, it just sets the tone for a so much more successful call for everybody involved.
I think you're exact. Sorry, Josh, go ahead.
I'll put myself a little bit on kind of front street. I was not great with these in the past. And it's been within the past probably 4 or 5 years that I've changed how I react to these and react to these patients and teach other people how to react to them, you know, and how to handle it. There's, you know, it finally dawned on me, why do I keep asking that question? What did you take? Like, in our heads, we already know, because we then tell them, but we know what you took. Stop lying to us. And so, you know, as I tell people, I'm like, okay, so I'm going to try and relay this as best as possible. I'm going to come to your into the bunk room tonight while we're sleeping after running all day, and I'm going to slap you in the face and wake you up suddenly, and I'll be 6 inches from your face like you just described, and see how you react.
Yep.
That's
exactly.
And now add in the hypoxic state, the hypercarbia,
Yeah.
a litany of other other issues that are probably going on. What was happening prior to them going unconscious? Were they alone, or was there a bunch of people? Was there some kind of issue going on before this? And now you're just adding more factors and things that you can kind of try and reduce that post Narcan administration.
And there tends to be so much ego on these calls. Like you just described, people asking what they took and, like saying that they're lying. Who cares? Like people lie to us all the time. It does not matter. What matters is that you document that the patient had pinpoint pupils and respiratory depression, that you administered naloxone, and then they woke up, right? Like that's all that we need. The fact that they're lying to us simply doesn't matter. And then, of course, there's always the consideration that people love to hate on patients with addictions. And I understand that, especially in an urban area, it gets exhausting running the same patients day in and day out, and overdosing and refusing and taxing the system. But like at the end of the day, we also have to recognize that the mental health system in this country is absolute shit and has failed these patients. And a lot of them have no option but to... I can't say that because we all have choices, right? But find themselves in a situation where they feel that they have no option to, other than to be in the situation that they're in. So, I know compassion fatigue is a real thing, and we all get burnt out with these types of situations. But we also have to recognize that, like, no one wants to live that way, addicted to an opioid, on the street, overdosing multiple times a week and whatever.
It's self-medication, right? You know, that's exactly what it is.
It's really, I'm so happy you guys are bringing this up because I texted Ken when I was watching this Painkiller. It's not really a documentary. It's more like I don't know what you would call it. But I mean, I don't know. It's on Netflix.
It's a dramatization. It's a dramatization.
But so really, So before I was in EMS, I was a pharmacy technician, and it was right around that 2013, 2012 time where I feel like that was one of the peaks of all this, and the amount of people that would come in with fake scripts that were obviously fake, and then transition into my career in EMS, and the amount of like opiate overdoses, and the folks that we'd see all the time. That documentary certainly hit deep for me, and it really validated a lot of things I knew already, that we were failing as a society. And on top of that, there was really this you always hear about it, but when you see how deliberate Purdue Pharma was in perpetuating this, and I know we're decades after that now, and there's so many other factors that go into the opiate crisis that we see today. But yeah, it also rubs me the wrong way when we just dehumanize like addicts. It really bothers me. I certainly agree with ventilation, oxygenation first. It's interesting, and I might have misunderstood you. I do have a question for you, Lindsey, on the topic of intranasal versus intravenous naloxone administration and not titrating to a respiratory rate. Did you say that there was certain evidence behind that? And if so, can you provide that evidence, please?
No, I did not say that.
Okay.
Although actually there is some good literature on why intranasal can be preferable over IV. I can try and find that study. There's been a couple podcasts on it recently and send it over to you guys so you can put it in the show notes. I just think in general, like when having these conversations with people across the world on social media, there's some places that this happens so infrequently that the idea of giving these microscopic IV doses and only titrating to restored respiratory drive and transporting to the ER, that is their common practice. And I understand that that probably is, what's best for their patient population. But when we're looking realistically at resource management, if we did that, especially you guys, right? If you in Baltimore City only titrated your narcotic overdoses to restoration of respiratory drive, and you transported them all to the ER like that every day, like how many extra resources are you using? And then there's people, on social media that'll say, well, just tube them. And I'm like, are you kidding me? You're going to take all of these resources to manage a ventilated patient in the ER for a narcotic overdose? I just think like when we are being realistic about this, Narcan can be given safely. Do they need 16 milligrams from law enforcement? No, they don't, right? But we can give an intranasal dose, reasonably allow for some slow absorption. It can last a little bit longer in their system, and then evaluate if transport is even necessary at that point. So I would say that's a little bit more personal preference, but there is some good info about IN being sometimes a little more preferable over IV.
I mean,
Sure, and
look,
that wasn't me trying to call you out. I genuinely am
No,
interested in, yeah, like that was really interesting for me to hear. And before Dr. Lawner comments, I know we're coming up on 2 hours. I do want to talk about pre-hospital bup as it you know how we're doing it in Maryland is interesting. You have to be connected with your local public health department, but and honestly, I would love to hear Dr. Lawner's thoughts on that. So, Dr. Lawner, all you.
this is a difficult subject to wrap up because there, as they say, there's a lot to unpack. I mean, I have RSI'd so many people that have been shall we say, resuscitated with naloxone. In Baltimore, we also have the challenge with co-administration. So let's just emphasize some of these key points. Number one, overdose is not simple. And I do agree. I mean, sometime we have more time about this, we can talk about my first experience with a patient encounter in naloxone. I mean, I think we have our own biases in EMS. We dehumanize addiction all the time. Our biases consciously and unconsciously influence our care. And this is a medical problem fundamentally with profound social implications. So number one, naloxone should be titrated to the reversal of the problem. We can talk about the nuance, but we agree that these indiscriminate dosages where you can kick people into withdrawal and you can potentiate, all of that sympathomimetic surge. There's a lot of negative consequences, not to mention re-expansion or, non-cardiogenic pulmonary edema. Naloxone is not a benign drug, and use it appropriately. I think we'd all agree that the only indication for these bolus doses of Narcan, where we're talking about the 1 and 2 milligrams, is for people that are not breathing. And even then, they should probably be ventilated first. So lots of consensus. The challenge is, I think it is within our power and purview to be a lot more careful with this. And as Lindsey said, there is a safe way to give naloxone. And if we talk about resource utilization, let's talk about the idiot futility of the current drug sort of addiction paradigm, where we're giving naloxone to reverse overdoses. They refuse. They continue to utilize these substances. And then we have all of the other downstream issues, such as HIV, hepatitis C, recidivism. And so we have to conceptualize this as something other than, let's just reverse this so they can refuse. We've got to expand the discussion to a harm reduction approach, which emphasizes not only buprenorphine, but quite honestly, and I think all of us touched on this, paramedic and EMS rescuer education, right? We have to understand some of the factors that motivate and that surround addiction so that we can get at the root of the problem. Because right now, this is a Band-Aid on a wound that is festering beyond our ability to deal with it. So there's lots of studies about buprenorphine, but the bottom line with these harm reduction paradigms is that you have to have buy-in from all phases. So if you don't have buy-in from the police, the bystanders, the receiving facilities, and the social support, it's very difficult to link people to care, because like any other chronic disease, people are going to experience recurrence. The challenge is we have to be able to match them to appropriate resources, whether that's buprenorphine, whether that is a home, whether that is mental, social, behavioral health resources. Otherwise, we're not going to get people off of that path. And the literature is fairly clear that if you have a comprehensive approach, which is tailored to these, which is actually tailored to what we know about addiction, you may be able to reduce some of the long-term complications. So there's lots of stories of success, but like any other public health intervention, it requires a lot of time with what is initially a lower return on your investment. But we've really got to reconceptualize how we treat overdose, and that really encompasses everything that we talked about here. Provider bias, how we reflexively give naloxone, how we educate bystanders and public safety personnel. There are a couple of other interesting ways to give naloxone, by the way. I agree that IV naloxone is oftentimes very aggressive and difficult to titrate. There's nebulized dosages, there's intranasal dosages. I think the challenge that we're seeing is that these overdoses are oftentimes not simple. So when you have things that are complicated by xylazine, sometimes it takes more than the usual dose of naloxone, and that leads people to believe that, oh, the Narcan isn't working, which really isn't the physiologic case. So again, the focus has to be on making this a a humanizing encounter, preventing harm, and really looking at what we can do in the back end to really stave off the deaths and the disability from overdose. It's a huge challenge.
What a great way to finish these. It was 9 points, right, Lindsay?
Yes.
Yeah, that was it.
Beautiful.
And only
Beautiful.
5 rabbit holes.
Yeah.
Well, that just means you guys have to come back 5 more times for whatever rabbit holes we end up talking about. Hey, listen, this was cool. I think we provided a lot of information in a little bit of time, and we're going on more than 43 minutes. I think that certainly for the folks listening, we'll have a ton of material in the show notes, so please reference that. And I just want to provide an opportunity both to Dr. Lohner and Lindsay. I mean, any closing comments from you all? I mean, what are your thoughts?
No, I feel like I aired all of my grievances during this conversation. This was awesome. Thanks for having me.
I just wanted to thank you and also the listeners. I think it's a distinct privilege and an opportunity to be able to participate in education, and we learn every day. And the podcast is just one feather in the cap. So to have this kind of podium is great. I really appreciate the time, and thank you always, for the opportunity. So always learning for sure. Great
Ken,
work,
Josh?
Lindsay, on your grievances, by the way. Good stuff. Good stuff.
Thanks for coming on, Dr. Lohner, Lindsay. It was a great time having you guys on here and talking about all these points and all the rabbit holes we went down and everything we brought up. Very, very entertaining episode, even as a host. It was a great one to be a part of. And the $50 words that the doc offered today, I think we totaled maybe about $150, $200 worth of words today. So thank you for those. We'll make sure that those are in the show notes so everyone knows how to spell those. Ken?
Yeah, no, I thought this was a great discussion. I had a lot of fun. Both Lindsay and Dr. Lohner, you guys are absolutely phenomenal. Thank you so much for coming on. Lindsay, don't forget to plug your stuff again before you go.
Oh, it's fine. Yeah, so my Instagram is the.prehospitalist. Just a little side hobby there with some education, but I think I learn more from you guys on there than people learn from me. So
Okay.
All right.
Josh, you want to close us out?
Sure. So once again, Dr. Lohner, Lindsay, thank you for coming on, joining us tonight with all these great 9 topics that we talked about. For everyone out there, make sure you like and follow Alert Medic 1. We got some great content coming out. Just like Lindsay said, follow the Prehospitalist as well if you don't already, which if you aren't, you should be. And if you're listening to us, you probably are following her. But wherever you are, have a good night, good evening, good morning, and be safe. And that's it. See ya.